Hello, hello. I first want to say thank you to the organizers for inviting me today to talk to you about cutaneous neurofibromas. So I want to talk about several things today, starting with the background on cutaneous neurofibromas, and I'm going to just say CNFs from now on. It's a lot of words, they're long words, so I'm going to shorten it to CNF for the rest of the talk. I'm going to talk about natural history, the social and emotional effects of CNFs, as well as treatment. I know only treatment is listed in the title, but all of these other things are really important to know about so that we know how to appropriately treat CNFs. All right, so let's start with background here. So neurofibromas develop within nerves, soft tissue, and skin. And the primary distinction between CNFs and other neurofibromas is that CNFs are limited to the skin, whereas other neurofibromas may involve the skin but are not limited to the skin. So here's a big overview of the whole talk, actually. So CNFs affect greater than 95% of adults with NF1, and although these tumors are not malignant, so meaning they don't become cancerous, they have a significant negative effect on quality of life. And the current treatments for CNFs are limited. They treat only a subset of CNFs and can result in scarring and then future regrowth. And there is a very strong unmet need for the development of effective medical therapies. All right, so now let's talk about natural history. In other words, how do CNFs develop over time? So there was a study of over 700 children and adults with NF1 that showed that the number of CNFs increased with age. And this study supported Hussein's 1988 survey in Wales that demonstrated over 99% of adults with NF1 reported having NF1. And this makes CNFs the most common medically significant feature of NF1 in adults. And by far, this was the most common concern that I heard in clinic by adults. Hussein also reported that 33% of women with NF1 described an increase in both size and number of CNFs during pregnancy. Another study investigating patient-reported pregnancy outcomes in women with NF1 found that 60% developed new cutaneous neurofibromas and 52% reported size increases. There were some dermatologists in Japan that counted CNFs over the entire body of 57 patients. And they were able to demonstrate an increase in CNF number by age group. And I want to point out the youngest age group of 0 to 9, they did count on average 11 cutaneous neurofibromas. So that's more than I think most of us realize. And I think these dermatologists, though, were hyper aware of the very early signs of what cutaneous neurofibromas look like. And then if you look at the oldest age group of over 70, there were well over 2,000 cutaneous neurofibromas on average. A few years ago, we published the results of a prospective study where we manually counted and measured CNFs over an 8-year time period. And we were able to show a significant increase in the CNF number over this time period, as well as a significant increase in the CNF volume. We measured the length, width, and height. And I do want to note that the rates of growth varied by body region. For example, the average volume of CNFs located in the back increased by 2.3-fold, while the CNFs that were located on the thigh or the arm region increased by 1.47-fold. And this is really important to know that there is this variability in CNFs by body region. When you're thinking about clinical trials, you want to try to standardize the data as much as possible and have reliable data as much as possible. So this kind of makes it a little bit more complicated for clinical trial data analysis. Okay, so what do we know? CNFs typically develop around the time of puberty. They increase in number and size with age, and puberty and pregnancy may be periods of rapid growth. CNF growth is highly variable. And one thing I haven't spoken about so far, but those studies that I did mention excluded individuals with NF1 whole gene deletions, and then there are some genetic variants that cause NF1, but not the cutaneous neurofibromas. So there are several studies that are excluding certain populations of people. Studies also counted only the raised cutaneous neurofibromas and excluded the flat and subcutaneous cutaneous neurofibromas. And then overall, monitoring CNFs over the entire body over the lifespan is needed, but this is really daunting. And a group at Johns Hopkins is trying to tackle this. You probably saw some of the advertisements on the screens between speakers. So this study is measuring cutaneous neurofibromas across all age groups, and they're trying to define windows of opportunity for early intervention, identify people most likely to benefit from treatments, and study the optimal methods for monitoring and assessing change in CNFs. And they're doing this by using a really cool method of whole body 3D digital photography. And you can see the machine on the screen here. You actually stand in this really large machine, and there are cameras all over this machine. And they will take a picture of your entire body, and it has really good resolution. And so we were able to actually see and measure cutaneous neurofibromas all over the body. So this study requires a yearly visit to Johns Hopkins for up to 5 years, and there is compensation that is available to participants. So if you're interested, please reach out to this group. All right, so let's talk about the social and emotional impacts of cutaneous neurofibromas, as well as the patient perspective, and what do patients want for treatment. Okay, let's start with Skindex. This is a measure, it's actually a questionnaire that measures the effects of skin disease on quality of life. It assesses 3 different domains. The first is emotion, like shame, worry, depression. The second is symptoms, like pain, burning, and itching. And the third is functioning, like sleep, ability to work, social life. And the higher the score, the higher the impact of the skin disease. Pierre Volkenstein surveyed 128 adults in France with NF1 and found that the visibility of these lesions was associated with negative effects on all 3 of those domains: emotion, physical symptoms, and functioning. And similar findings have been reported in various other countries as well. So the Skindex is a great tool. It has been used in several studies. However, was not validated, and it was not CNF specific. It was just asking generally about a person's skin and not features specific to the cutaneous neurofibroma. So Pierre Volkenstein's group modified the Skindex so that it is CNF specific, and this is the first quality of life tool that's been validated for CNFs. And this means it can be used across different studies reliably. And this is important for measuring treatment response in clinical trials. Okay, so together with the RAINS International collaboration, I saw Scott Plotkin walk in. I'm sure he's happy that I'm mentioning this. This has been a great group to work with. We developed a survey to assess the perspective of adults with NF1 regarding CNF's impact and treatment for designing patient-centered clinical trials. And we sent these surveys out through the NF registry. If you are not part of the registry, please sign up. This is a great opportunity for you to participate in research and learn about new research opportunities that you may be interested in. Okay, so back to our survey. 548 people completed it, and nearly 60% of these people were very much or extremely bothered by CNF, by appearance, location, number, and size. More than 50% of individuals reported being very much or extremely bothered by CNFs on the trunk, the face, as well as the arm, so more visible areas of the body typically. And 244 individuals provided a free text response. And I've sent several surveys out for various research studies. Most people do not want to have to type out a response. They usually just want to click a response. So this is a really high number of people that felt very strongly about this question. So the question was, how do cutaneous neurofibromas affect you? And we had a lot of different responses, and several of them were quite powerful. So analysis of these responses showed that CNFs affected psychological health like self-esteem, depression in 74% of people, physical health like pain and itching in 50% of people, and social well-being like intimacy and social isolation in about 33% of people that responded. We also explored the perspectives of adolescents with NF1 and their caregivers about CNFs. 28 adolescents and 32 caregivers responded to the survey. Adolescents reported having several negative feelings about CNFs, particularly feeling worried about the potential progression of their CNFs, and that was about 50%. We also asked about CNF treatment, and we thought this was really important to ask this group because CNFs, they're not life-threatening, and experimental therapies come with a risk. So we wanted to know, what is the willingness to treat these CNFs, and what are the risks that people are willing to take, when you're talking about children and side effects. So topical medication followed by oral medication was the most preferred treatment, and this was also the same for the adults that we had previously surveyed. Adolescents and caregivers most often replied that CNF treatment should be initiated when cutaneous neurofibromas became bothersome, not necessarily like preventative treatment, but when the CNFs became bothersome. Okay. I had some more notes, but the computer over here has no signal anymore. I can go ahead and just talk freely, though. So we also asked about side effects that they were willing to risk, and no surprise, children were not really happy about the idea of having side effects. Pain and nausea and vomiting were the main side effects that they were not willing to risk. And that's important information to know because the current MEK inhibitors that are FDA approved, they do have some side effects, including nausea and vomiting. All right, so to summarize this section, CNFs can negatively impact the social and emotional well-being of adolescents with NF1. Adolescents and caregivers are willing to explore experimental therapies, and this is only as long as the effects are minimal, or as long as the side effects are minimal. CNFs seem to have more significant negative effects on the quality of life of adults. That shouldn't be a surprise. Adults tend to have a much higher number of cutaneous neurofibromas. And most adults with NF1 are willing to consider experimental therapies for treatment and risk more side effects than adolescents. So again, clearly there is a strong unmet need for the development of effective medical therapies, and we hope that the results from these surveys help guide the design of patient-centered clinical trials. All right, so now finally to treatment. We can loosely group the different types of CNF treatments into two groups, the procedural-based therapies and the experimental drugs. Starting with the procedural types, these are some of the only currently available treatments. These treatments require highly trained medical specialists, including dermatologists, general surgeons, and plastic surgeons who are familiar with NF1. I know that there was a question in the chat for this session asking who should remove the CNFs. It really depends on what is available to you at the institution that you go to and the types of CNFs that you have. Some dermatologists are more easily available to remove these CNFs, but if you have a CNF in a very sensitive area like the breast area, then a plastic surgeon may be a better option. So challenges facing removal of CNFs include tumor regrowth from incomplete removal, scarring, and importantly, there is a cost. Surgical excision can be used for removing both small and large CNFs, and surgical excision is required to remove the larger CNFs that are globular in shape. The top left photo is an example of a large globular CNF that was surgically removed. So surgical excision does yield favorable postoperative results with minimal scarring, and there is high patient satisfaction. And surgical excision has been utilized for removing only a few CNFs, as well as mega sessions, where CNFs are removed in one, or many CNFs are removed in one operation. These mega session techniques require general anesthesia, antibiotics, and postoperative pain management. In contrast, excision of a few CNFs may only require local anesthesia, which costs significantly less than a multi-hour operation that requires general anesthesia in an operating room. Okay, so there are also a few laser-based therapies that are available. These often include photocoagulation or YAG laser and CO2 laser. Kreischbaumer et al. Prospectively compared photocoagulation lasers and CO2 lasers in 21 patients that had over 15,000 CNFs. And they showed that the photocoagulation lasers had improved postoperative pain, shorter wound healing, less side effects like scarring and necrosis, and a subjectively improved cosmetic outcome. The laser-based therapies like CO2 laser can cause hypopigmentation or depigmentation. And you can see, hopefully you can appreciate the picture that's on the right-hand side. This is a person that had the CO2 laser. And where the CNFs used to be, there is now a white spot. It's much lighter compared to the normal skin tone. Laser-based therapies, particularly the photocoagulation laser, tend to be highly expensive and likely only found in well-funded practices in large academic hospital settings. Okay, another technique that is available is electrodesiccation. This uses a probe with an electrical current that dries out the tissue by heating up the water that's inside. And this results in a dried out bump and a small wound takes its place. So in photo B, you can see how there's the wound after treatment. And the goal is for healthy skin to form over that treated area. This also has been used to treat hundreds of CNFs at one sitting, but like the mega sessions for surgery, it does require general anesthesia in an operating room. And you can also get the hypopigmentation and scarring. And this procedure does have high patient satisfaction as well. Okay, so these currently available treatments rely on several factors. We've talked about some of them, and this includes the availability of equipment, individuals that are trained to perform these procedures, time, the number of CNFs you want to remove, the size and shape, location, and desired cosmetic outcome. So lots of factors. For the larger CNFs and those CNFs that are located in more cosmetically sensitive areas like the face, neck, and breasts, surgical excision and photocoagulation is recommended. For areas that are not as cosmetically sensitive, like the abdomen, chest, or back, the CO2 laser and electrodesiccation is recommended. Okay, here are some less common procedure-based therapies. They're less common mainly because there aren't as many institutions that have the equipment to do this, and there are less people that are trained to perform these procedures. It's not because they're not as good. We actually don't have a lot of good data yet to support how effective these are, but you may have heard some of these or seen these published or discussed on social media. The first is radiofrequency ablation. This is when a needle-like probe is inserted into the CNF, and then radiofrequency waves are emitted, and they heat and destroy the tissue. Then there's photodynamic therapy. This is a two-stage treatment that combines light therapy energy with a drug that's called a photosensitizer, and this is designed to destroy cells after light activation. Photodynamic therapy is a well-established cancer therapy, and a few groups are exploring this for CNFs. And then finally, the third procedure is high-intensity focused ultrasound. This uses sound waves to heat and destroy the target tissue that's located in the dermis and the epidermis, which means it could treat CNFs that are located deeper in the skin. So for all of the other treatments that I've talked about, other than the surgery, it's only treating the CNF that protrudes above the skin. But this type of treatment is actually able to get down into the skin and get the cutaneous neurofibromas that are deeper in the skin. Okay, so this is a paper that's hot off the presses. This is the result of a prospective randomized trial. It was published just this month. The trial evaluated 4 different therapeutic approaches that are currently FDA cleared for other dermatologic indications, not CNFs. The first is deoxycholate injection, alexandrite laser, a diode laser, and radiofrequency needle coagulation. Deoxycholate, you probably have not heard this term. It induces loss of adipose tissue, but you may have heard the brand name. It is Kybella, and you may have seen commercials for this. It's used to treat the fat below the chin. When they compared these 4 different treatments, there were no scarring or significant adverse events. So that's good news that there's several different types of therapies that had pretty good, that did not have significant side effects. And all 4 therapies reduced or cleared the CNFs. But there was large variation between the tumors and the participants. They did note that the alexandrite laser and the deoxycholate were fast and the least painful. All right, now let's talk about the experimental drugs. These consist of medications that can be taken by mouth like a pill. They may be applied to the skin or injected into CNFs with a needle. The first group, the ketotifen, imiquimod, and diclofenac, are used to treat inflammation. Ranibizumab is a VEGF inhibitor, so this prevents the growth of blood vessels. Then there's rapamycin and everolimus. These are mTOR inhibitors. These have been used to treat features that are associated with another condition called tuberous sclerosis that also has skin growths. And then there's another drug that has recently been listed on clinicaltrials.gov called difencyprone. It's a potent topical sensitizing agent that has been used for many years to treat alopecia. So there's no data yet on difencyprone that has been published that I could find, but all of the drugs that are listed above that, there have been some publications on that. Most of these studies were in very small groups, and there was really variable response. So in general, most of these drugs didn't show a really significant response, and it definitely wasn't in a large population. So now that brings me to the MEK inhibitors. So you've probably heard about MEK before. So MEK is in the signaling pathway that's overactive in individuals with NF1. And MEK inhibitors can block the signaling pathway. And there are currently 3 different MEK inhibitors that are on clinicaltrials.gov that are being used to treat CNFs. This is mirdametinib, selumetinib, and NFX 179. And I'm going to talk specifically about selumetinib and the NFX 179 because there's been some pretty promising data that has been available to the public. And I'm really excited about these MEK inhibitors because, as you probably have all heard now, selumetinib, that is known, the brand name is Koselugo, was approved in 2020 to treat inoperable plexiform neurofibromas in children. And most people that take this drug have a 20% or more decrease in the size of their plexiform neurofibromas. So this means that MEK inhibition is a validated therapeutic approach for treating neurofibromas. And additionally, when selumetinib was still in clinical trials for treating the plexiform neurofibromas, Dr. Brigitte Wiedemann and her amazing team at the National Cancer Institute suspected that the CNFs may also be getting smaller, not just the plexiform neurofibromas. And so she reached out to Bruce Korf and myself at the University of Alabama in Birmingham to partner on a clinical trial using selumetinib to target CNFs. So we enrolled adults with NF1 at both UAB and the NCI. The length of the trial was 24 cycles, which is approximately 2 years, and there were 9 required study visits. And if you didn't know, selumetinib is an oral medication or a pill, so that means the drug goes to all of the cells in the body, not just the neurofibromas, and in this case, not just the cutaneous neurofibromas. The primary outcome measure for this study was measuring the CNF volume, so again, measuring the height, length, and width. And then we also looked at CNF counts and the Skindex. And it's important to note here that we used the original Skindex. This was before Pierre Volkenstein was able to validate that CNF-specific Skindex. So we used paper frames on 3 different areas of the body, so the back, abdomen, and either the arm or the leg. This was a very similar procedure that we used for the natural history study. And each of these locations within these frames had to have at least 6 cutaneous neurofibromas that were at least 4 millimeters. So if we get any smaller than 4 millimeters, it was really hard to measure those cutaneous neurofibromas. And we measured these CNFs with calipers, and there's a picture of what a caliper looks like on the bottom of the screen there. So there were 11 total participants who enrolled in this study. There was a target of 16 participants. This low enrollment was primarily due to the COVID-19 pandemic, and unfortunately, as a result, the study was terminated early. While there was an even distribution among ages and genders, our cohort lacked racial and ethnic diversity, with 100% of participants identifying as white and non-Hispanic. So these images show the visible response to selumetinib treatment. The top row of photos are from one participant that was taken at baseline, so that is photo A. After 20 cycles of drug, where they had a 33% decrease in average CNF volume, that's in photo B. And then after 24 cycles, the participant came off of drug about 24 days earlier because they had an adverse event. That is in photo C. They had a 0.7% increase in CNF volume, and they did come off study at that time. The bottom photos are from another participant that was taken at baseline, so that's photo D. After 12 cycles of drug, they had a 42% decrease in average CNF volume, that's photo E. And then after 24 cycles, they had a 27% decrease in average CNF volume. All right, so this figure is showing the average CNF volume change for each participant over time, and each line is a different participant. For those who completed 4 cycles, that was 7 participants. The average volume reduction was about 18%, but there was a pretty wide range from 2 to 43%. There were 6 participants who completed 12 cycles, and the average volume reduction was 37%, and the range was 8 to 81%. The dotted lines indicate participants who came off drug at least 21 days before the study visit where we measured those CNFs, and there was evidence of regrowth. So this indicates that if we are going to treat CNFs with a MEK inhibitor, it would need to be pretty long-term. The lines that are not connected indicate participants who missed evaluations, and this was during the COVID pandemic. Okay, so this figure shows the average CNF volume change for all study participants combined. The average volume change ranges from about 20% after 16 cycles to 34% after 12 cycles. This figure is of the Skindex quality of life data. There wasn't a clear connection between the scores and the volume response. However, there was a statistically significant improvement in the emotion score for participants after cycle 1. So participants went on drug, they were very excited, and they saw some early changes, and I think you could see that in the emotion score there. Unfortunately, we weren't able to see any significant response later on. And that could be due to a few things. One, it could be that this scale was not validated. It was not CNF specific. It was asking generally, how do you feel about your skin? And as we are going to talk about in more detail, there are pretty significant skin side effects that are associated with selumetinib. And so when you're asking someone how they feel about their skin, they may be happy about the CNF shrinkage, but not happy about the acneiform rash that's all around it. So we did not feel that this was the greatest example of efficacy or clinical benefit from the patient. All right, so let's talk more about those adverse events. All of the participants experienced at least one adverse event, and there were a total of 650 total adverse events reported. These ranged from mild, so a grade 1, to life-threatening, a grade 4. The most common adverse events were the acneiform rash or dry skin, so that was in about 37% of people, and gastrointestinal events in about 17% of people. The grade 3 and 4 adverse events were drug reaction with eosinophilia and systemic symptoms, and shortened to DRESS, as well as hypertension. All right, so in summary about the selumetinib trial, participants did experience some CNF volume reduction, and this is similar to the percent volume reduction that was seen in previous plexiform neurofibroma trials. Everyone experienced at least one drug-related adverse event, and it's really not clear if the degree of the CNF volume reduction led to a clinical benefit. This study highlights the challenges of treating CNFs with a medication that often causes skin and other adverse events. And the administration of the Skindex assessment, especially the validated CNF-specific Skindex in larger studies, may determine if CNF shrinkage is truly associated with that improved quality of life score. In the future, studies enrolling a larger and more diverse cohort would help to improve the generalizability of these results to a broader NF1 population. Okay, let's now talk about the NFX 179 trial targeting CNFs that is sponsored by Inflection Therapeutics. And I want to thank Dr. Kavita Sarin for allowing me to present this work. She presented this in 2 different webinars in January. These were CTF-sponsored webinars, so some of this information may look familiar to you if you attended either of those webinars. For this study, there were 24 different sites that enrolled 199 participants, so this was a really large study. These participants were randomized into 3 different groups. One group received a lower dose of the drug at 0.5%. The second group received a higher dose of the drug at 1.5%. And then the third group received a vehicle only. And this means that they received something that looked very much like the drug, but without the active ingredient. And unlike the selumetinib trial, this drug is a topical gel, so it's only applied to the skin, and it does not go to all of the cells within the body. The study was lasted for 6 months, and the gel was applied once daily to 10 target CNFs. So the primary outcome measure for this study was very different than the selumetinib trial. For this study, the type of response they were assessing was the percent of participants with at least 5 of those 10 treated CNFs that shrunk by at least 50% or more. They did also look at the volume change and then scales assessing change from both the doctor's perspective as well as the participant's perspective. This figure is showing the percentage of participants that responded to drug. 24% of participants who applied the vehicle responded. 35% of participants who applied the low-dose drug responded, and 44% of participants who applied the high-dose responded. They also looked at a global impression of change scale. So this is a little bit different than the Skindex that I was previously talking about. This is a single question answered by the participant whether the CNF changes were meaningful. And at the end of that 6 months of treatment, patients reported that the CNF changes were meaningful at higher rates if they were on the drug, either the high or the low dose, compared to the vehicle. And overall, CNF improvement from baseline was highly correlated with CNF responder status. So they were able to see a link between the drug response and the patient-reported outcome measure. Okay, so there were 153 subjects that completed the total treatment period. There were 46 discontinuations due to loss of follow-up, 29 discontinuations due to other reasons, and this was equally distributed through all 3 groups. And then there were 17 discontinuations due to adverse events. The discontinuations related to cutaneous adverse events were dose-dependent. 13 discontinuations in the higher dose group was for dermatitis, pruritus or itchy skin, erythema, so redness, pain that was described as stinging, and rash. There were 4 discontinuations in the lower dose group. This was for dermatitis and rash. And of note, topical treatment of the target tumors for corticosteroids for like itching and dermatitis were not allowed in this protocol. This is something that we used in the selumetinib clinical trial because we do know that there are those skin adverse events. There were no concerning systemic adverse events or abnormal lab findings, and this is likely due to the drug only being applied to the skin. It's not going all over the body. So in summary, the NFX 179 clinical trial showed significant dose response. The topical gel was generally well tolerated. The global impression of change scale strongly correlated with response. And there are plans underway for a phase 3 clinical trial. And for this trial, they are going to use those topical corticosteroids. So this should help with some of those drug-related discontinuations that they saw in the phase 2 trial. All right, so in conclusion, we have 6 minutes to go. Okay, so there is promising clinical trial data for CNF treatment in adults, but reliable and standardized patient-reported outcomes are really needed. So using that global impression of change scale and that validated CNF-specific Skindex is really important to be able to link the response or change in the CNF size to what the patients perceive as beneficial. Also, adverse events, particularly those that affect the skin, are common and need to be addressed. And currently, there's no data for CNF prevention trials or trials that are enrolling adolescents. So hopefully, we'll see some of those in the future. Okay, so I have a few acknowledgements. There's several groups here I want to acknowledge. There's the UAB group, particularly Bruce Korf, Tammy Skelton, L.A. Haynes, the National Cancer Institute group, so Brigitte Wiedemann, Dominic Pichard, Andrea Gross, Rains, Jayshree Blakely, Scott Plotkin, and Kavita Sarin. Kavita and I are co-leads for the Rains CNF working group, and that's been a great experience. And I would also like to thank my funding sources. Okay, so I'm going to make a hard turn real quick. It has nothing to do with CNFs, but it's something that I'm very passionate about, and that is trying to help parents tell their child that they have NF1. This is something that I heard in the clinic many times. Parents really struggle with this. And so about a year or two ago, we did a study exploring the patient experience of telling their child that they have NF1. And this study revealed a need for resources to support caregivers during this process. So genetic counselors like me, the Children's Tumor Foundation, and patient representatives worked together to create a parent guide as well as a paired children's book to help both the caregiver and the child through this process. So the parent guide is called Telling Your Child About NF1, and the children's book is called Super Emerson. So the parent guide was informed through advice from caregivers with children with NF1. Some of the topics include reasons to tell your child they have NF1, how to prepare to talk to your child, approaches to discussing NF1, possible responses the child might have from learning this information, and then also developmental considerations. Because if you have a really young child, you're going to talk to them in a very different way than an adolescent. And so that's also something that we found in the previous study that parents really wanted was an age-appropriate language to use. The children's book, again called Super Emerson, follows the main character named Emerson. They're 6 years old with NF1, and this book addresses topics like basic NF1 education, school struggles, communication with trusted adults, talking with their peers, going to the doctor, and coping with anxiety. It's also very interactive. I'm just so excited about these resources. I really do hope that it helps parents and children through the process. So even if you've told your child that they have NF1, or if they know because they're going to doctor's appointments, these resources can still be used to help fill in some gaps or discussions that you're uncomfortable about or may not understand. Or not, well educated on, like inheritance, things like that. So very excited. This is almost finalized. It's in the illustration phase now. It should be ready in May. So please, reach out to CTF. It's going to be freely available on the CTF website. So please share this information with anyone you think that might benefit from it. Okay, so I'm finally done now. Thank you. What questions do you have? There's
I
a
have
lot
a
to talk
question.
about. Yes.
So
Hi.
going forward, when you do a selumetinib trial with the cabo, would there be a study with the CNFs while doing that?
I'm sorry. Repeat the question. I
think there's a clinical trial coming up with selumetinib and cabo.
Ooh.
Would you look at CNFs while you're doing that study?
I'm not a part of that study, so I don't know. I hope so.
We can find out.
We can find out. Is that what you said?
Yeah, we can do it. We can find out.
I mean, it's not easy to measure. I mean, it takes a lot of time to get comfortable measuring those CNFs. So, but you know what? I don't think you necessarily have to measure the CNFs. I think the patient perspective and how they feel about their CNFs, and if they think that there's a difference, I think that's really important. So, asking that single question and giving a patient that form with that single question could be really helpful and really easy for trials to include within their methods. There's a question up here.
First, roll tide, first of all. And then, so you talked about the cycles. How long was each cycle patients went through?
Each cycle was 28 days, so about 1 month. Yeah. So the study was supposed to last for 24 cycles, so about 2 years, but most of our participants didn't manage to make it that long for various reasons. Yep.
With the procedure-based therapies,
Yeah.
what's the rate of recurrence?
It's variable. I think truly the recurrence might depend on the person who is trained to perform those procedures. You really do want to make sure that you're going to someone who is familiar with CNFs and know how to appropriately remove them. But with that said, people tend to be pretty satisfied after, with all of those different procedure-based therapies that I mentioned. I still think that we could do better at trying to figure out which therapies are best for who. I think some additional studies like the one that I presented that compared the 4, I think we could do more and compare because there's other different procedure-based therapies we could compare. Yeah.
Okay, thank you. We are unfortunately out of time for more questions.
Thank you, everybody.